my name's John, and I'm doing my presentation on a historical analysis of HIV in the U.S. blood supply. So I think when we're talking about HIV, we have to talk about the HIV epidemic. Where did the HIV virus originate, and what type of virus is it? The HIV virus originated in Kinshasa, the Democratic Republic of the Congo, Africa. What's important to know about this virus is that it is zoonotic and that it originated in chimpanzees, where humans were exposed to infected blood. Basically, you had these hunters that were hunting these monkeys for either pelts or maybe food. It didn't go into it. However, at some point they did come into contact with the chimpanzee's blood, and that is when the HIV virus crossed over. It officially crossed over in the 1970s, and by the 1980s, it is suspected to have infected 200 to 300,000 people in over 5 continents. So basically all of them except Antarctica. It's a retrovirus, and it is actually part of the subgroup lentivirus. And the disease that it caused is AIDS, and it will progress to AIDS if it is untreated. What is AIDS? AIDS stands for Acquired Immunodeficiency Syndrome, and this occurs when the HIV virus has attacked and destroyed the body supplies of the CD4 lymphocytes, and then it will produce a skewed CD4-8 ratio, leaving the host immunocompromised and open to other sources of infection. So generally, it's not the HIV virus that's killing its host directly. Instead, it is weakening its immune system so much that the host cannot fight back. So the HIV epidemic. One of the interesting facts about the HIV virus is that for a long time, we didn't even know the virus existed. They knew that this virus was more prevalent within the MSM community, the gay community, and they knew that it was causing an acquired pneumonia from Pneumocystis jirovecii, sorry, I can't ever say it, and that it was causing Kaposi sarcoma in these patients. And then you have these other opportunistic infections that normally people wouldn't develop unless they were having this damaged immune system. It wasn't until 1983 that the virus was isolated and given a name. It was different than what we know as HIV. It had a scientific name, and they renamed this for simplicity, human immunodeficient virus. And putting this in perspective, in 1981, out of the 270 gay men that they had identified as having this virus, 121 of those people died. That's a 49% mortality rate in these patients. Look at SARS, COVID, which we have going on right now. We're looking at less than 1%. This is pretty bad. But looking on to today, and it is still an epidemic, it is still present, it is still going on, it is still an issue. There are 37.9 million people living with this virus. But there is some good news with this. As for people that are receiving treatment, as of 2018, 50% of these people have access to treatment and retrovirus treatment. You have your post exposure prophylaxis, your Truvada for the LGBT community, and really any community, but it is very prevalent in the LGBTQ community. And then you have the antiretroviral therapy. The virus is transmitted through contact with bodily fluids of the infected. The virus is predominantly transmitted via sexual means, but can also be transmitted through an open wound. So when saying that it's transferred through an open wound, you're looking illegal drug use, unprotected or risky sex behaviors, blood transfusions, cuts, and wounds. So now we can actually start talking about the blood supply and how HIV infiltrated and what it did once it was in the blood supply. So looking at our single donor components pre-1985. So at this point, we don't have any screening. We don't have anything like that. And the first case of transfusion-acquired HIV was in 1982. Almost all cases originated in this period. There are very few new cases. And up till 2001, of those cases, 14,262. Better though, our current rate is 1 in 1.5 million. I mean, very unlikely for it to happen. The risk of contraction in an infected unit is higher than any other known exposure. This means Hep C, trypanosoma, any of these other infectious disease, Hep B, any of these things we're looking for. The virality rate is upwards of 90%. 90% of these units that are transfused, that person is going to get HIV. Just think about that for a minute. 90%. 90% of these people that get this rare unit are going to get this disease. This data is independent of age, sex, reason for their transfusion, or the component type that is transfused. It is not. Yeah. The age of the unit matters. If it's less than 8 days, we're talking a 96% infection rate, and over 21 days, 50%. However, we can slightly decrease this if we are washing the cells. This is not something that we do commonly, therefore it's not as important, but I do think that we need to mention that. You might want to wash these if you have a known HIV patient. You might want to wash the cells. Most of these people die within 6 months due to their underlying issues. They're not dying from the HIV, they're dying from whatever originally required them to get that blood transfusion. The post-1 year mortality rate is not affected in the United States by HIV acquisition. So like it says, most of these people are dying from the original reason that they're actually needing a transfusion and not the HIV itself. The patient's age and immunocompetency are factors in progressions to AIDS, as is the virus in the primary host. So you're looking at the virality, you're looking at their viral loads. These are all important. Mean acquisition time to AIDS is 8.2 years, and the development of AIDS is equal to the time that it would take to occur in a person who acquired the HIV from the other non-transfusion related means. Single donor components post 1985. Antibody testing. I'll elaborate more in how this is done in the upcoming slides, but I just want to go ahead and put this out there. It was the game changer. This is what really changed the game and how we are preventing HIV from infiltrating our blood supply. A combination of this antibody testing, community awareness, your voluntary deferrals, your donor education and awareness, and your recruitment practices has steadily reduced the rate of infection, leaving the U.S. currently between 1.5 million and 1 in 1.8 million. Those are pretty good odds. I mean, this is a pretty rare thing to happen now. And even though this PowerPoint is specific to the United States, I think that as an MLS, we need to be thinking on an international level as well, because we live in a globalized society. The U.S. blood supply is safe. However, considering that you have these nations like U.S., France, Britain, Germany, these are all first world nations, first world countries. We have these resources that we can use to do this type of surveillance on our blood supply and make sure that we're not giving out these HIV infected units. This isn't true for the entire world. Only 20% of the world's safe blood units are available to 80% of the world's total population. This is a huge disparity in the amount of units that are actually safe. Only 43% of the WHO's 191 member states are testing for HIV, and we're looking at 80 to 160,000 infections from HIV occurring every year in these nations. This is more of an issue of healthcare disparity because of income and the resources that are available, but this is still a big deal, and as MLS students or MLTs or MLS practitioners, we need to be aware of this and how it affects the community and how it affects our particular community, our particular labs. This needs to be in the back of your mind. Looking at plasma-derived blood products. To produce plasma-derived blood products, plasma from 2,000 to 30,000 donors is pulled and processed into a single batch or a lot. One HIV-infected donor can contaminate an entire lot of product and consequentially infect each of the recipients if HIV is not neutralized by sufficient heat, cold ethanol, or other treatments during production. A variety of different blood products can be manufactured by successive precipitation with increasing concentrations of cold ethanol. Individual fractions are then further processed, during which time, partially concentrated fractions from as many as 100,000 donors may be combined. And this was a direct quote from Dr. Elizabeth Donegan. So looking at our other products like Rogam, that thing that we use to prevent anti-D being developed in our Rh-negative moms, luckily there's no documented cases of HIV contraction from Rogam, which is derived from the con fractions. However, as an interesting note, in my reading, I did discover that Rogam, because it is so concentrated, can give a patient a transient positive HIV antibody test due to the high titer antibody in the concentration. I think this is interesting because this is such a unique case that we're seeing these people that don't have HIV, but these antibodies passively crossing over to our patients, and so that we're going to see that positive antibody test, but everything else is going to be negative. Anywho, these people don't actually have the HIV, they're just exhibiting the passive antibody transfer. Here's a pretty picture of Rogam for those of you that's never seen the box. Other products, in particular hemophilia. So we're looking at our hemophilia concentrates, recombinant, cryo, all of these things. People afflicted with hemophilia A or B are dependent on factor transfusion. Therefore, these people would have been affected severely by the HIV epidemic. It is estimated that 50% of these people with hemophilia during this time, we're looking 1970 upwards, were infected with the HIV virus. Of these with severe hemophilia, about 90% of them died. We're talking in the terms of thousands of people who developed AIDS and died. That's a lot of people. Just thinking of these hemophiliacs that died in the millions, or sorry, in the thousands. That's a lot of people. But what was the game changer? The biggest thing was antibody testing, and I can't stress that enough. I've stressed it before. Antibody testing was the game changer. But as an additional mode of safety, there was the advent of methods to inactivate the virus, so these heating methods and such. And then we had the formation of recombinant factor, these ultra pure. And you usually use these forms in your HIV patients due to the fact that it reduces exposure to these foreign antigens, which could be speeding up their process of conversion from HIV to AIDS. And the rate of acquisition is dependent on age. It's equal to that of MSM or the TRHIV, so transfusion related. Irrelevant in the severity of hemophilia or the amount of product received. So it doesn't matter how many units they were given. It doesn't matter how severe their hemophilia was. It is all the same rate of acquisition. Testing of HIV in donor units. So let's actually get into the testing. The first thing I want to discuss is the antibody testing itself. This is done via immunoassay, also known as Anaylsis. It can currently identify the virus within 22 days after the viremic phase. ELISA, they're plates with wells, they're coated with antigen, and when you expose it to the patient antibody, it's going to bind. And then you use a counter antibody that's going to come in, bind to that initial antibody, and that's going to be what you detect. Your unbound antibody is going to be washed away multiple steps. And then in 1996, the FDA mandated the use of the P24 antigen, decreasing the identification to 16 days post-viremic phase. And note that this test in particular is for screening, and it has to be confirmed. This is not your confirmatory. Also, this test does not account for people who have been exposed and have not yet developed a detectable amount of antibody to the HIV virus. It's almost 100% sensitive and specific. It is a very good test. Next is our NAD testing, our nucleic amplification testing. We're looking for RNA, HIV1, and this is all done in mini pools. This PCR is used to test multiple donors in a single pool. If all of the units are non-reactive, the unit may be released. If one of your PCRs come back reactive, the individual unit has to be pulled, tested individually, isolated the infected unit, and then you go from there. If they all come back as negative, they can be added back into the supply. And according to the ARC, the next step is to then differentiate these reactive units between HIV and HA2 using an ELISA. Going on to the donor questionnaire, I apologize. The questionnaire is designed to aid in donor donation eligibility. It's included with educational materials, and it does follow FDA recommendations. In regard to HIV, attempting to identify risk factors. We're looking at your sexual history, drug use, history of prostitution, the gay community, the intravenous drug users, positive HIVs that are already known, and risky sexual practices, or in some cases, whether you've been in prison or jail, that's also going to be a risk factor. I just wanted to take a second to go over the controversy that we have in not only the blood bank community and the MLS community, or just among the LGBTQ community. A lot of people see this as discrimination against the LGBTQ community. Because of the history of the virus, there is an association between the LGBT community and the HIV virus. And one of the issues with this is that even though these LGBT people are more likely to be exposed to the virus, it doesn't give a necessary to apply this broadly against the entirety of the community. Currently, MSM has a 12-month deferral. This was changed in 2015 from a lifetime deferral, and right now during the COVID epidemic, they have actually changed it to a 3-month deferral. This is currently in place by the ARC, but the ARC has been perfectly open about this. They want to have a conversation about it. They want to have a dialogue. We want more studies to make sure that we are giving the safest blood that we can to our patients. And a lot of recommendations is that we should go to an eligibility based off an individual assessment, and how that's going to affect MLS, who knows. So with that said, I do just recommend that you take a second and think about this and how it affects MLS, how it affects us, how it affects the blood supply, and how that we as techs can help this move. Moving on, I do want to look at the look back procedure, because after you have that positive, this is the next step you're going to do. This is going to be where we're looking back. So let's say that donor A donates some units and then later donates some more units, but this time he's coming up reactive for HIV. This is going to initiate that look back. The whole idea behind look back is to, guess what? Look back to find previously collected blood products from a donor who is now reactive for a particular infectious disease marker. In particular, we're looking for HIV and Hep C. The previous units within a particular time frame, which varies by the infectious marker, should be destroyed if not already transfused. If a previous product within the look-back period for HIV or HCV was already transfused, federal guidelines mandate notification of the recipient or next of kin and the physician of record. Any of the units that are still on your shelf need to be quarantined. Any of them after confirmatory testing need to be destroyed, and there needs to be a notification of the patient and the MD if these units have been transfused. So moving on to the final phase, I want to talk about a particular case study that happened in a combination of Missouri and Colorado in 2008, and we are going to look at somebody that did acquire HIV through means of a transfusion. So our background is November 2008. Kidney transplant patient receives unit of fresh frozen plasma and subsequently is infected with the HIV virus. Looking at our donor analysis, we have a male in his mid-40s and he is known to be a regular donor. A recipient analysis, who we're going to refer to as patient 1. Patient 1 received 1 unit of donor packed red blood cells. He died 2 days later following a cardiac procedure. No pre or post-mortem specimens were collected. His infectious status is unknown. And then we're going to look at our main point of this case study, the recipient analysis 2, who we're denoting as patient 2. Patient in kidney failure and on dialysis since 2005, receiving a kidney in 2008 from an HIV-negative donor at EIA and NAT. Most recent 2005 HIV test was negative, and at the time of the organ transplant, our patient reported no medical or personal risk factors. Patient received no blood products in the time between dialysis and transplant. Looking at going further into our case study, we're going to look at the dates now. So in June 2008, our donor donates and is HIV negative, EIA and NAT. He reports no risk factors on RESQ, so our questionnaire, and he's not compensated for the donation. This donation transfused into 2 patients No specimens from the donation were retained. In November 2008, the donor donates again, and this time he's HIV positive at EIA and NAT. He again answered no to the risk assessment. It placed on indefinite deferral list. All units from this donation were destroyed, and the MSHD, the Missouri State Health Department, was contacted, and this initiated our look back. They wanted to see if the June 2008 units might have been within right before he seroconverted. The donor denied the interview initially, but then subsequently admitted that he was a married man, but also having sexual relations with other men outside of his marriage. He stated that the sex was anonymous and that it was done when intoxicated. In August 2008, 1 unit of FFP was given to patient 2. December 2008, the Colorado Department of Public Health and Environment notified of the plasma transfused to the patient from the HIV positive donor. So his doctor, when the patient came in December 2008 to the transplant clinic, he got these following results. He had the negative serum EIA, so we don't have antibodies yet. We have the positive NAT with a viral load of 7,240 copies per milliliter. No bueno. And a CD4 count of 48 cells per microliter. That's really low. Our patient is placed on antiretroviral therapy and continued on mycophenolic acid. In June 2009, he was retested and it showed a normal physical exam, an undetectable viral load. We had a doubled CD4 count. The EIA is now reactive. The Western blot was indeterminate, and reactivity to non-viral P38 and P42 bands, and a weak reactivity to the GP120. He's infected. HIV DNA from blood specimens collected from the donor and the recipient were amplified and sequenced at the CDC is what that should say. Comparison of the genomes showed that the virus from the donor and the recipients were greater than 99% identical, confirming that the donor's 2008 donation was the source of this patient getting HIV. He did get HIV from that unit that was contaminated. I just wanted to put out some thoughts on this. So our system is obviously very effective in reducing the chance of transfusion-related HIV. That 1.5, 1 in 1.5 million, 1 in 1.8 million. But we're seeing that a lot of the burden is laden to the donor in being honest. A simple breakdown at this level led to the development of HIV in our patient. How should these breakdowns be addressed? Should there be a criminal liability? How do we as MLS advocate for a safer and more stable blood supply? How can public awareness be spread further? Is Truvada an answer? Is Truvada something that we need to invest more in? I think these are just some of the things that you can take from this case study. In particular, I think that we need to think of education. How can we as MLS help spread blood education in safer transfusion practices? How can we stress people being honest? We have a very large part to play in this. And finally, I do want to go over my conclusion and the epidemic today. The rate of infection for HIV in regard to transfusion is incredibly low due to the comprehensive testing, increased public education, and individual deferment. We can conclude that mistakes still happen, things can still get through. There's about a 10-day window according to the ARC in which the patient will test negative. That's actually positive. And we have to realize there's a reliance on donor integrity when answering those questions. Looking at today, 37.9 million people are living with HIV. The total mortality can be counted in the million due to AIDS. In terms of the United States, through the PEPFAR, it's the single largest donor to international HIV efforts in the world, including the largest donor to the Global Fund to fight AIDS, tuberculosis, and malaria. There's about 5,000 new infections a day in the world. However, in Western and Central Europe and the US, we have a 35% decrease in deaths. We are getting better at treating this. We're getting better at preventing this. And if you have any questions, feel free to leave them in the comments and I will answer them as I can. Here's the references if you want to see where I got the information or just want to read more into it. I would highly recommend doing that.